Hi, everyone. Welcome to week 2. This week, we'll be talking about what I call context matters, or what I've entitled the lecture to be, which is Context Matters. This is developing a contextual understanding of a person and their presenting problems through the lens of the I Can Start treatment model and through the mental status exam. And so, this is going back to the chapter reading from the Kress textbook, chapters 1 through 3, and also introducing the mental status exam. And so, just to make sure that we're on the same page, I think I had forgotten this in the lecture video from last week, but in order to prepare for week 2's class, please make sure that you have completed the mental status exam reading, which is attached in the module, the week 2 module, and that you've watched the mental status exam video that I created. You need to do this before class because we are going to be doing exercises and activities around your understanding of the mental status exam. We're going to be looking at a couple different character videos, and we will be going through this in greater detail. So that is your preparation. In addition to reading, that is your preparation for class this week. In this lecture, I'm going to be introducing context and why it matters. And again, this is going to be through the lens of the I Can Start vignette. So, context matters. I want to spend a moment on the diathesis stress model. I know this is introduced in the textbook. I can't remember if actually this is introduced in the DSM, but this is an important factor in our conceptual understanding of the relationship between one's genetic predisposition to a disorder and environmental stressors. Don't worry about what this says on Andy plus speed. You'll know this later. I couldn't take it off for whatever reason, but these two factors, so what family history of genetics has to say about a person's predisposition to one or more disorders, plus what's happening in the context of the environment, this theory identifies that leads to the emergence of this disorder. I very much believe that this is accurate, that somebody's vulnerability to mental illness, plus the amount of stress that they experience, especially at different developmental times of one's life. And as we go through the DSM disorders, we'll see about the emergence of different disorders and what the average age of onset is. I don't spend a ton of time talking about that, but there are notable areas. And a lot of times, as an adolescent, when many things are changing, when just chemically, hormonally things are changing, the exposure to one's stressors can often exacerbate or increase a person's predisposition to mental disorders. And so, if we compare somebody who's like in the 1%, that they have the same genetic predisposition to major depressive disorder, for instance. We compare that person in the 1% to somebody that's like in the 99%, where they do not have any resources. They live in environments that are either very unhealthy, that are unsafe, that just there's a huge disconnect with regard to overall resources and care. This theory argues that this puts a person at a much higher risk for the emergence of a disorder that they are predispositioned to. And so I think that this is an important foundation just for us to understand how the context that we will talk about in this lecture really can, again, yield to or can have some sort of correlation with the emergence of someone's disorder. I'm repeating emergence of the disorder a lot, but this is going. So let's just understand that. Now I'm going to move to Annika from chapter 2. I'm going to reintroduce this vignette to you. So Annika is a 42-year-old immigrant from India. English is not Annika's primary language. Hindi is her native language, and she speaks broken English, which makes communicating with her counselor difficult. Annika expresses that her difficulties communicating in English make her uneasy and uncomfortable around others. Annika reports that she is not happy and attributes this to not making many friends since her move to the United States 2 years ago. She expresses that since her move to the United States, she feels lonely and isolated. She indicates that she feels lucky to live in America, but she wishes she could feel happier. She misses her friends and family in India and longs to see them again. She explains that she is having a hard time being away from everyone. And I would say if she speaks broken English, it probably wouldn't be as fluid as that. But let's just pretend for the sake of this vignette that that's exactly what she said. And I hope I'm not butchering this person's name either in terms of pronunciation. But Annika has 2 children, ages 14 and 15. Annika does not work outside the home, and her husband works as an engineer in a cellular phone company. Annika sees her primary role as tending to the home, and she cooks and cleans the family's home and provides care and oversight of her children. Annika likes to paint, and when she lived in India, she would often make crafts with her neighbors, but she has not felt motivated to draw or paint since coming to the United States. She expresses that she feels lonely and misses how in India she would socialize with her neighbors and family. She has had difficulty connecting with her neighbors here in the United States. She is Hindu, as it was explained, and attends a temple, but temple is about an hour's drive away from her home. Her community does not have a significant Indian population. Due to this, Annika stays in most days and often feels like she has no one to talk to who would understand her. Annika says that she is having trouble sleeping and has frequent headaches. She reports that she often worries about various issues, i.e., her children and their future, money, her family. She has been wondering if she should get a part-time job, but then feels very anxious when she thinks about doing so. She indicates that her husband is quiet and does not offer much support. At night, he comes home from work and eats his dinner and then isolates himself in his study. As she goes about her day-to-day activities, she reports often that she feels sad and worried. As the first session ends, the counselor is aware that communication in this session is difficult, and she is left with more questions than answers about Annika's situation. The counselor is aware that she knows little about Indian culture, but will educate herself more for the second session that will take place next week with Annika. You know what? I'm also reading this and thinking it's probably Anika is the way that her name is pronounced. Anyways, just secondary thought. So you are from now on going to be presented with some sort of clinical vignette in some way, shape, or form. As far as it relates to your studying, as far as it relates to just the course of this class, as far as it relates to future classes, working in treatment teams, studying for exams, like clinical vignettes are going to be a part of your lives as therapists. So, in introducing the I Can Start model, we are really going to better learn how to frame what information we pull out and where it goes, essentially, what's important, what information can help us better understand or conduct the process of differential diagnosis to be able to identify what are DSM related symptoms and how are these clinical symptoms best fitting into a diagnosis? And then what are other contextual factors that we can understand as far as a relationship to the presenting problem, barriers for treatment, opportunities for treatment planning, resources, community that can be looked at as strengths. Unfortunately, not in this particular situation, but we're going to pull out different aspects of this vignette and categorize it in ways that are much more helpful for you to understand what's going on, why it's happening, how we would frame our conceptual understanding of this problem, and what to do about that as far as treatment is concerned. So more on, let's just say Anika, more on Anika later. Clearly, the objectives of this class, or the main objective of this class, is to educate you on the diagnoses within the DSM-5-TR, right? In addition to that, then I really want to equip you to be able to apply said diagnoses to clinical situations where you've already determined from that context that the presenting issues are problematic enough to warrant a diagnosis, meaning that this is kind of a bookend. Context provides a bookend for us in understanding how problems came to be identifying whether those problems are significant enough as far as dysfunction, as far as distress. Those are two key factors for us to then be able to determine or look at this through the lens of a diagnosis, i.e., to be able to give it a diagnosis. But then what we want to do with that is to then apply this combination of context and diagnosis to treatment. And because problems don't just go away once we've identified why these problems are happening. They don't just go away once we've given it a name and adequately given it a correct diagnosis. We then have to be able to make sure that we have the proper tools, we're using the proper evidence-based treatments to help that person manage the problems in the context of what they're presenting with. So, Lindsay, how do we organize that information? How do we know what's clinical and what's just information? And then lastly, how do we know what to do with what? I don't know if I really love that sentence, but how do we know what to do with all of this content? Well, we will start with the I Can Start model, and then we're going to go from there. So we are going to very much use this as a framework in the course of our class. This is going to be a template. You will see different versions of this template. And so again, the textbook introduces this as far as individual factors. That's really focusing on, hey, what's coming up for you as you are introduced to this client or this patient? What is present for you as you are working with this person? We often think about this as far as like transference, well, countertransference. You will learn more about this through the lens of the signature theme. What I'm going to talk so much about in this lecture is what are the presenting concerns, i.e., what is the client's or the patient's chief complaint in their words? And then what do we know about their background? How did they get to this point? And what are the notable cultural or environmental contexts for this client? Really considering the nature of the situation, the culture, their SES, family dynamics, etc. How does this presenting problem live within the context of this person's life, past, present, and future? What we will be very much working on in this course is sharpening your skills on assessment and diagnosis. So pulling out of from a vignette, pulling symptoms reported out and condensing them, organizing them, and then being able to start putting them into different possible diagnoses and then comparing those diagnoses against one another to whittle down a much more provisional and then hopefully working or principal diagnosis. So we'll talk more about this in the next couple of weeks, especially. But you will again get an introduction to this particular week in class. From there, we talked about this in lecture 1. We'll identify what is the necessary level of care for this person as far as their level of impairment and what kind of support do they need to reduce the impairment and make sure that they can stabilize. What would we recommend? We always want to focus on strengths because those can be key for understanding resilience, understanding motivation, really protective factors, ways that we can incorporate other people, places, and things into treatment. Then looking at the treatment approach, what evidence-based approach have we selected and why is this appropriate for the client? Within this class, I know that we're going to be talking about, I have this on here as an example, CBT, DBT, ACT, that there's a lot of like very straightforward foundational theories that are discussed. You will have much more of a working understanding of this when you get into practicum, hopefully. But this is just going to give you an appetizer to this within our course. And then we'll talk about aim and objectives for treatment. So like what's the overall goal of therapy? Often it's to be able to increase or decrease, to be able to, it really aligns with what the person's chief complaint is. So the primary aim, we really want to make sure that that is aligned with the chief complaint. As I talked about this in week 1 of the lecture, this is like the golden thread, the start and the finish. And the aim and objectives, or the aim is going to be realized, through the objectives that we identify for this client. These objectives yield to research-based interventions. I'm going to talk about all of this. And then what sort of other services and referrals would be helpful outside in combination with what we are able to provide, because we can be fantastic therapists, but we cannot do everything. We don't need to do everything. And so it's essentially looking at, in order for this person to really manage their presenting problem and for us to be able to help them realize the overall or experience or achieve the overall goals of therapy, what other additional resources and sources of support does this person really need that we would recommend for assistance? So individual factors, I said countertransference, so negative or positive. So gosh, okay, I have to make sure that I am not giving you 20 minutes of every slide. I'm just saying this so you will hold me accountable. Every therapist is going to come into the therapy room with different factors, right? And so whether that's your competency, whether that's the way that you connect and click with your client, whether that is your background and your history, just the practices that you can bring to the table as far as what sort of treatment you practice, what you offer, all of those things influence your individual factors and the way that you are going to view treatment for this particular person or group of people. Countertransference, this can be something that's like, I really have a difficult time with this particular client. And sometimes we know exactly why we have a difficult time. And other times we have to really piece this together and reflect on this and talk about this with somebody else. Spoiler alert, it is often related to our family systems. And then we can certainly have positive countertransference with our clients and our patients. And both are really important for us to identify because both create biases. Doesn't mean that one is better than the other, but both can essentially help and hinder us as far as our awareness and the way that we treat the person with whom we're treating. And then our culture, right? Being sensitive to our own values, our assumption, our biases, especially about what we bring into the session. I know you have a lot of classes that talk about this, and just what we know about other cultures and populations. And so, I don't know. I know there is direction about it's not okay to ask people from different cultures to educate us. I still think that that rings true in a lot of ways. And usually what I do is I'll just say like, hey, what I know about your culture is this. Is that accurate? Or hey, doesn't this behavior fit really within like a cultural context for your background? And that's just an opportunity for our clients to say, yeah, that's exactly it, or no, that's not really has how it's been for my family, or that hasn't really been what it's like for my community. And so we can really check in about that. I do think that it's a two-way street. We want to do as much homework as we can, but I've just learned that when I come to the table and say like, "Hey, this is my understanding," being somebody that works in a hospital, me, Lindsay, works in a hospital. Oh, I didn't share that information with you. I'll talk to you about that in class. Um, I've learned a lot about Filipino culture. And when I presented information to a group of nurses about how they talk about mental disorders, my understanding is that you really can't talk about mental disorders in the Filipino culture because you're labeled as crazy. And that often rings true. Well, a lot of people's experiences have been that. But I also hear just information about like, hey, we don't really want to overly generalize, or I think this is like maybe overly presumptuous of how it is across our cultures. And so I've just learned to really be to keep a balance of what do I know versus what do you know, and how can your knowledge help equip me so I can best help you. Contextual factors. Okay, this is really the bulk of our conceptual understanding of this model, but a lot of these factors have to do with what's going on paper. So when we talk about specific demographics, this is who a person is, where they come from, race, ethnicity, what their cultural background is, what's going on with their socioeconomic status, their orientation, their relationship status, like all the stuff, the demographics that people fill out on paper, literally fill out on paper. I'm going to move to the right. Then we certainly have to identify when we are, and let me back up for a second. This is all under the umbrella of when we're conducting a clinical assessment. So when we are presented with a bunch of information or when we're meeting with somebody to sit with them and get to know them from a structured clinical standpoint, we are seeking to be able to identify all of these factors. We certainly may not be able to identify all of this in the in the context of one session or one intake session, but we really want to fill this in as much as possible. And I use this vision, or pardon me, this image of like a framework. I also use puzzle pieces to be able to, oh yeah, I did this in the bottom corner. Fantastic. To be able to remind myself that a person's life is a lot like puzzle pieces. And I can best treat them when I have as many of the puzzle pieces obtained and put together as possible. And so this is just like my side recommendation to make sure that you are never just glossing over information, especially when you have questions where you're like, wait, I forgot about this, or wait, I never asked about this. When we don't assume things about people based on information that we receive, on information that seems incongruent with what they're saying, this is just your permission to be as curious and thorough as you can, as the time that you have available with a person allows for, because we just want to fill in all these components. This better informs us about the chief problem and how it came to be. And again, it will guide our treatment. So with cultural and environmental influences, this is really looking at how does a person's background with regard to their culture, how does their background as far as their living environment impact their presentation, how does their current environment really inform and guide the emergence of this presentation and how this presentation is alive and unwell, so to speak. And so this is where the DSM certainly talks about this, and we'll go into this in week 3 of our lecture too, but just how does culture define the problem? Does culture actually define that someone's behavior is problematic or not? What is the impact of a culture's perception of mental disorders and help seeking? I used that example of the Filipino culture, what I know, especially in nurses, as a framework for my understanding of what keeps people that I work with from seeking help. I'll just take this as an opportunity. Currently, in the year 2026, I am working for Sharp Chula Vista Hospital. I essentially work to support all of our employees in the hospital with their stress and wellness. So I don't do any patient care in this hospital. I have a really unique role that I love so much. And I always say that you're going to have to pull me out by my ankles. But I have learned a lot. I've been in this role for just over 4 years, and I've learned a lot about nursing culture because my job started in the wake of COVID to be able to help nurses that are that were really traumatized by COVID, to help them stabilize, to get them connected to resources, and to essentially see about keeping them from leaving their jobs, to be able to help manage their burnout. And so I've just learned a lot about nursing and medical culture in general, but I had a very difficult time in my job for the first 6 months because unlike how it was at Sharp Mesa Vista, where you round with any sort of coworkers and you ask, hey, how's it going? And you have 20, 30-minute conversations with your coworkers about what's going on and what they need support with. Like, it's just the easiest thing ever when you work alongside other mental health clinicians. But nobody wanted to come to me and talk to me when I was at Sharp Chula Vista. And I was like, what the heck? I know that you're not fine. I just saw you go through a really challenging situation on the unit. Why are you telling me that you're okay? And not every person that works at Sharp Chula Vista is Filipino or Filipina, but a large amount of nurses in general are from that background. And so I learned that it was like, oh yeah, we're not really allowed to talk about this. That like if I talk to my parents about this, they're going to say that I'm crazy, that I'm not good at my job, and that I'm not strong enough. And so those factors were always incredibly important for me to identify of like, hey, this is understandable about why you haven't been seeking help, but let's think about how you've operated along these lines for the past 30 years. And no wonder why you have little insight about the nature of this problem. No wonder why you are feeling guilty every time that you seek to ask somebody for support. No wonder why you're really struggling to manage the death of this patient because you have been told forever that you don't have permission to talk about it. So those are things that I took for granted and I don't take for granted anymore in the same way. But it's really seeking to deepen your understanding of what's this person like and why. What are their background factors that essentially either support and emphasize or support and um, lead them to being in the room with you, and what are the factors that get in the way for that. So I could keep talking about this, but and then we talk about the family system, right? What are the family background factors? I said spoiler alert, this has a lot to do with family as far as countertransference. A lot of things do. This is why I'm a systems therapist. This is why marriage and family therapy is oriented around the family system, because everything affects something else, right? Whether that is exposure with genetics, or this is obviously nature versus nurture, right? Um, that backgrounds with regard to families shape a person. They shape the person's perspective of their problem. They shape the way that that problem is cultivated, the way that that problem is lived and experienced. There's just uh, a lot about this. And this is why we will forever have a job. I'm not relishing in this, but this is why we will forever have a job, is because families are messed up, unfortunately, right? And our relationships mean everything to us, yet we don't always have relationships that are lined up to be able to proactively help us through difficult times. I'm going to skip over recent stressors and functionings, but I'm going to jump to predispositions. This is another demographic type of component on paper. These are the things that we can't control. These are the things that have already happened in the past to this client, who they are, or the patient, who they are in their waking self, right? So this is, when I say attachment, this is obviously family background stuff. How do they normally present? How are their behaviors, their actions, their moods, their type of cognitive functioning? What does that usually look like? And as it relates to the chief problem, how is that different from what they're presenting with in the treatment environment? What is a person's temperament? What are developmental considerations that we have to take into context of just what was their growth and development like? How do they think? What's going on with their bodies? How do they typically engage with people? I was talking to a client. I work with a family. I think I only have one family right now. And we were talking about the moms, her mother is in her mid 80s. And my client, the mom, is in her 60s. She's really struggling with taking care of her mom as far as supporting her mom emotionally. Her mom she has resources, but she lives in an independent living facility, and she doesn't like it. She doesn't feel connected to the people in her community. She doesn't really engage in a lot of ways. She really isolates herself, and she's becoming increasingly more depressed. And so I guess over the holidays, what she had announced to the family and extended family was that she was going to move out of the independent living facility, and she was going to buy a house and stay there and just be isolated. And so my client was coming into session saying, I don't know how to support my mom when I don't agree with this. I think that this is going to be really detrimental to her as far as her isolation. I just think that this is going to make it worse. And so we were talking about, well, what's her baseline? And my client was saying she's never really been somebody that's been outgoing. She does not actively socialize. Like, she's not somebody to like roam around a social environment and make relationships. Relationships have always been really difficult for her. And she's a kind of a quiet person. And so people don't engage with her easily. Those are all predispositions that if I were hypothetically working with this grandmother, that I would have to know and take into consideration when identifying how would I frame this problem. Would I still call something major depressive disorder, or would I still call something depression if this has forever been somebody's baseline? Um, I'll say the context too is that this person, this grandmother, i.e., mother, has been a college professor for a long period of time. And so she is not teaching. She's, again, in her late 80s. And she really has not done a lot as far as learning. And so she's really stagnant overall in her life. And I would imagine that she does not get to experience a lot of joy as far as growth, as far as contributions, etc. And so all of that, this is what I talked to the family about, was like, hey, let's take all of this context into consideration. And if we think about it through that lens, how does this frame the problem? Then is it just a matter of somebody that's being obstinate, or is it a matter of somebody that really is struggling because they have in some way always been disconnected? And so how do we use that information to provide the best type of compassion, care, and support for this person while managing our expectations? I don't have that anywhere on the slide, but I think that that's really important to identify, is like, what expectations do we have for a person? And is that aligned with reasonable expectations that we should have for a person? So, last part, I swear this slide takes the longest for me to go through, but we have to identify what are the recent stressors with regard to a person's life, and what has their functioning been like. So what's currently influencing the person's behaviors? What's currently influencing the presenting problems? What sort of day-to-day overarching stressors do they have to deal with? How do they deal with them? Are they dealing with them effectively, ineffectively? If they're coming in for treatment, they're probably not dealing with them effectively. But we have to identify how and when, and what does that look like? And do they have times that they can use effective strategies? What gets in the way of that? I mean, this is really where we're just asking so many questions. Are they using substances to cope? Are they using food to cope? Are they using shopping to cope, sex to cope? Like, what are they doing that is helpful and also hindering? Do their relationships cause distress? They're like, you know what? Everything is going, I have a good network of people in my life, but I just cannot stand my boss. I'm not saying this for real life. I'm very thankful to have a lot of wonderful bosses. But it is so often, especially in this like last few months, that a lot of my clients have had boss or coworker issues. Everything else in life is great. Uh-oh. I live on a block where we have a mix of very elderly people and newer families. And so it is often that there's some sort of EMS fire service that's coming by. So if you hear the faint sound of a fire engine, just know that that is happening in the context of my neighborhood. Ha, see what I did there? But ultimately, this is where, again, we're piecing together these components of a person's life to ask, what is happening now to cause an issue? I think we forget about that, especially early on in this process of your skill set. You have all this information and you're like, okay, cool. I'm just going to take this like at face value. And it's like, but why is this a problem now? Especially if we're looking at like, person has struggled on paper for for a long time. They've had a messed up family environment. They have lived in a community where resources are not easily accessible. They have struggled with sleep. They don't take their medication. They don't exercise, blah, 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 blah. Why is this a problem now? And so we have to really question, has something been a tipping point? Is it that that they're here not because they're choosing to be here, but because they've been mandated to be here? We really want to understand, why is this happening now in the present moment, and why was this not deemed as a problem before? Okay, so I'm done with that slide. But all important things to consider. So another way to think about this is, how do we use the information that we have obtained to frame a clear understanding of the problem? So first of all, we start with the person's chief complaint. When, for the sake of the chief complaint, as it relates to our class, you're always going to use that in quotes. So I want to improve my relationships in quotation marks. And then we have to take into account, okay, what information do we have about the chief complaint, how it came to be, what's been that tipping point for them? Why is this a problem now? Why wasn't it not so much a problem before? What about this person's background makes them susceptible to psychological problems? We've talked about genetic factors, environmental factors. Is their behavior abnormal in the context of their environment? That's a big one. I have this on another slide. Is their behavior abnormal in the context of their family, in the culture, in the context of their culture, in this particular situation? Maybe I'm repeating this, but again, why is this a problem for the person now? Is this a problem? Are we seeing these symptoms occur across all contexts, or is it just within one context? Depending on if this arrives at the need to provide a diagnosis or to um, formulate a provisional or working diagnosis, different diagnoses have different criteria as far as how many contexts these symptoms need to be demonstrated across. And so that matters. What we want to ask ourselves, do the symptoms, circumstances, and other variables match? Are they congruent with one another, or are they incongruent? And often, if they're congruent, then that really just gives us a much more clear, cohesive understanding of that combination of problems plus predispositions plus chief complaint equals a much more comprehensive diagnostic understanding of a person's issues. But there are other times where it's like, okay, you're saying that this is a problem, but I'm doing an assessment and it does not make sense in the context of these relationships. Or like, you're saying that you think that you have depression, but none of this matches as far as the diagnostic framework of this. And it doesn't seem like it's this. So why does this person think it's why does this person think it's depression? Why are they calling it depression? And how do I better just understand what that means as far as a person's motivation? I could ask a million questions about this. This is how my clinical mind works, as I just want to understand. Wait, what about this? Wait, why is this? Wait, I'm curious about this. Often I don't have to teach this. There are plenty of times where I do. And so this is my permission to, this is what I'm doing, is giving you permission to just keep asking questions. The other questions that we have, what prevents the person from recovering? What prevents the person from just having resilience in the first place, or being able to recover without the need for therapy? What about the person, what about who the person is influences the way that they view this as being problematic or not? I probably need to change that sentence later on, but what about this person either allows for their insight or gets in, or well, how do we say this? Allows for insight or presents a problematic barrier as far as the development of their insight, right? Again, if they come from backgrounds where we don't talk about stuff, then they have not had a lot of practice about insight development, emotional intelligence, right? There are lots of different, this is like equifinality. Different roads can lead to the same destination for understanding why or why not. And then last question on here is, what systems are in place to either help or hinder this person from recovering? Again, what resources do they have? What does their community look like that can aid in this process of their recovery? What gets in the way? So many questions that can help us that we have to ask. So here's my question to you. With each of these clients, think about, is this behavior abnormal? Is it normal? How does it fit within the context? So my first client A, says, yeah, this album, okay, I'm not going to try to do a rap voice, but yeah, this album is dedicated to all the teachers that told me I'd never amount to nothing, to all the people that I lived above the buildings that I was hustling in front of, that called the police on me when I was trying to make some money to feed my daughter. Does anybody recognize this? Baby, baby, it was all a dream. I used to read Word Up magazine. This is Notorious B.I.G. for all you youngins that don't know your rap history. Um, Now, I took this information because I thought this gives a snapshot that we can do a lot of different things with, right? And so, what he's saying, and this is Notorious B.I.G.'s, I would imagine, lived background when he was alive, of his upbringing, growing up in environments where resources were much more scarce. And so, people often had to resort and have to resort to crime. And so, being in living environments where the police were called because somebody's engaging in unlawful behavior. This information does not necessarily mean that we would deem this behavior to be diagnostic. It's problematic. We also have to look at what's going on for this person's degree of distress, of dysfunction, and does that information, along with the clinical context that we have, the clinical information that we could identify as symptoms, we don't really see a lot of psychiatric symptoms within this particular set of information, but does this warrant the need for a diagnosis? What's the context of the problem? So we don't really have a lot of clinical information. And so we're a far cry away from actually being able to make a diagnosis. We just have a snapshot. So while we don't have diagnostic symptoms, what we do have is contextual cultural background. And I'm saying culture with regard to normalization of engaging in unlawful behaviors for the sake of crisis and survival. Depending on what backgrounds we come from, depending on what environment we live in, we might either very much pathologize that or look at this through the lens of an incredibly normal type of behavior for someone in a similar environment. And so, again, we don't have enough information to be able to warrant the need for a diagnosis for this, but the context of this problem is survival. The context of this problem is a trauma response. The context to this problem is a lack of resources. And so I think all of that is relevant that we want to look at as it relates to better understanding the nature of this problem and better understanding the components that would cause us to identify this as clinically uh, relevant or something that is abnormal and problematic in an objective clinical perspective. Or are we calling it a problem and this person isn't calling it a problem? That's all relevant information. So it's how we are viewing this. And is that aligned with how the rest of the culture, the rest of that society, that the rest of that community is viewing it? Or are we and our biases coming from our backgrounds viewing this as problematic when to the person, when to the community, it's not? Separately, in my life right now, I'm reading this book about this little girl who is raised by a member of Hell's Angels in a rural area. And her biological father is an awful person. The book's called All of the Ugly and Wonderful Things. I don't know if I recommend reading it right now, but there's a lot of trauma in it. But it's fascinating because the environment that she grows up in, a lot of people are using meth. There is a lot of intimate partner violence, a lot of unlawful behavior. She just has a fair amount of adversity that she experiences so far in the 12 years of her life that really speak to why problems in her life exist. But if you were to ask this character, hey, what's problematic? The problems that she would list would be very different than the problems that a clinician outside looking in would list. And so we have to look at that alignment of context, what's reported as problem, and then what we identify as far as abnormal, normal, diagnostic, not something that we want to provide a diagnosis for, etc. This other chief complaint from client B says, yeah, I got kicked out of another ILF, so independent living facility, for stealing people's clothes. The background information from a contextual assessment was this client, and this is one of my old students. This is a patient that they were working with at Alvarado Parkway Institute. So the patient was saying, I steal a lot of clothes from people. I have a closet full of clothes, but I always think that I'm going to run out. So I take everything that I can when in the context of being in different ILFs. I don't have any family. It's just me and all my my material possessions. So this is where I ask, is this behavioral abnormal? Is it normal? Does this information warrant the need for a diagnosis? What's the context of this problem? So what comes up for you? Is this behavior abnormal? For the person, what would they say? They probably would say it's normal. If we were to ask the manager of the ILF, they would say it is not normal for them to steal people's clothes, right? In the context of this person's life, they are very alone, right? So we can identify that there's some purpose of this symptom, that by being around these material possessions, that allows for this person to feel connected, to feel that they have some sense of value or purpose, to be much more. My husband's watching football downstairs. Sorry if you can hear that. To be much more oriented toward taking things that make them feel a particular way. So if we were to further diagnosis, I think with my student in this situation, demonstrated due diligence, and this patient did not meet criteria for kleptomania. But this was a behavior that was problematic because, again, she was getting kicked out from a safe living facility for stealing. And so there's an objective way to look at this, and there's a subjective way to look at it. It's a matter of, again, what is the distress, dysregulation, the dysfunction that it causes for a person, and would a diagnosis either help to better frame that problem or not? Assessment and diagnosis. So if the assessed context needs a name to frame the diagnosis, then we get to start looking at finding which diagnosis would best fit with the clinical information that we have. So this is where we pull out the symptoms or the problematic content, and we'll talk a lot more about this next week in week 3. But we'll talk about this in week 2 and week 3 and moving forward. But we then pull out some different options of diagnostic possibilities and compare them to one another. And then from there, we choose the best diagnosis that best fits the complaint, the context of the problem, and the nature of the person's impairment. There are plenty of times where we're working with somebody, they have a presenting problem, we do an assessment, come up with a provisional diagnosis, and again, that all lines up. Then there are plenty of times where it's like, oh, I thought I assessed this correctly, or I thought I had all the information, and then they drop some sort of informational bomb on you, or you're like, oh, I didn't even know about the grandfather, or wait, what happened when you were a child? Um, and that really shifts the landscape of it. It's like, oh, okay, that makes sense, or that does not make sense. I need to go back to the drawing board and really deepen my understanding of what's happening diagnostically and change the way that I'm perceiving this and conceptualizing this. But I will have many opportunities for you to really practice this process of differential diagnosis. And on that note, this is a term that I'm going to use a lot. Now, this is rule out or ruling out or rule outs. Okay, so contrary to the assumed connotation of this term, if I say, hey, what are your rule outs? So if we're looking at, I'm going to go back to client B, of, hey, you have this person is stealing, it's causing disruption in their lives. They also are isolated. So can we apply this to any working diagnoses? Well, again, we would, so I'd be like, hey, what are your rule outs? I'm going to rule out kleptomania. I'm going to rule out, I'm just going to say this for the sake of it, generalized anxiety disorder. And I'm going to rule out, this is totally a stretch, antisocial personality disorder. This is not me stigmatizing or like jumping to conclusions, but I'm just thinking of what I know of different clinical backgrounds and presentations. And I'm like, this could be aligned with what we would normally see with one of these three diagnoses. This is not accurate at all, but I'm just using this as an example. So when we hear that we have diagnoses to rule out, this does not mean that we are just going to throw those out, because otherwise it would be like, I'm going to rule out 99% of the DSM. What this means is like, what is the small bank of diagnoses that we are considering and essentially pitting against one another to help us arrive at a provisional or a set of working diagnoses. So if I have a client that's coming in with reports of difficulty sleeping, restlessness, bad mood, hopelessness, and worry, then I would immediately think of a few rule outs for this. It could be major depressive disorder, especially with regard to the bad mood, with the difficulty sleeping, restlessness, hopelessness. Those are all really common words that are expressed when a person is talking about major depressive disorder. When I hear worry, I always go to generalized anxiety disorder, because that is one of the fundamental components or fundamental symptoms that are diagnostic within that framework. It could also be bipolar disorder, difficulty sleeping. We'll talk about this. So like, that is a key factor, a key symptom that belongs to the diagnostic set of criteria. And so this is where it's like, you know what? I'm whittling this down and I'm thinking that it could be one of these three. So holding these possibilities in mind, then I would go through the process of differential diagnosis to gather more information from the client and to essentially compare that information. I'd fit it under the umbrella of major depressive disorder. Does this meet 5 out of 9 symptoms for major depressive disorder? Generalized anxiety disorder. Does this meet, I'm forgetting, is it 3 out of 6? I always forget how many you need in generalized anxiety disorder to meet criteria. But does it fit under generalized anxiety disorder, or does it fit under bipolar disorder? So I'm going to really sit with that and to make sure that I can find the best match, and then identify the correct provisional diagnosis from there. And again, it could change, but that's what that usually looks like. Now, from the diagnosis, I'm looking at necessary level of care. From the diagnosis and the presentation of the person as it relates to context, as it relates to their level of impairment, we would also want to know, what is the necessary level of care? How dysfunctional is their presenting set of information? And what sort of care do they need? So questions that could help us determine functioning: are they going to work? That's usually one of the biggest questions, the most that's like the lowest hanging fruit, because most people do need to work, right? So if they're not going to work, then that can be very helpful in us being able to determine how a person is functioning. We also want to look at relationships, because relationships are easily the most often and the most that can be the easiest barometer, other than work, to determine a person's degree of distress. So if I get home from a very stressful day, I have to make sure that I am not being a biatch to my husband. He is the first person to support me in all way, shape, or form. And usually that's like my indication of like, if I'm being short to him, if I don't want to hear him talk, then I need to know that like there's something going on that I need to take care of. If I didn't have that insight, if I didn't practice this, I practice this in my role, both as a therapist in my private practice, and especially in educating a lot of non-clinical people, i.e. medical people, about stress management. But this is like the one thing I say is like, hey, how are you treating other people, and how is your stress interfering with that? And so that can be a helpful way for us to be able to identify level of impairment. If somebody exercises and they're not exercising, that's important. If they never exercise, and like there's something to be said about what their health, what determinants of health are, and what might be contributing to their presenting issues. Are they taking medications that they need to be taking? Were they ever taking them? Are they suddenly not taking them? Are they making their bed? That is not a clinically evidence-based practice, but I promise you, if you ask this question 2 adults, this is like always my ongoing assessment question is like, do you make your bed? And I have found that when people are in overall degrees of distress and impairment, that less often their beds get made. Now, if you are listening to this in your early 20s, then contextually, maybe this isn't so valid. If you're talking to a 60-year-old person who has not made their bed in 30 years, to me, I want to know more about that, right? I want to know what the rest of their house looks like. I want to know what their baseline looks like. I want to know how well they function in work and relationships. It's not everything, but it's an interesting diagnostic marker for impairment. Is that away from their baseline? Oh, so many questions. Are they getting dressed? Are they avoiding others? Are they leaving the house? Are they sleeping all day? Are they taking care of their basic needs? If a person is not brushing their teeth, they're not putting on pants, those are huge markers for a potential degree of impairment. Again, it might be something that's their baseline and has been at their baseline. And that might be because they have developmental difficulties or their developmental degrees of impairment, and they have never done that, or they have always needed some sort of assistance. But if they are away from their baseline, where they usually don't sleep all day, they usually do brush their teeth, they brush their hair, they wash their face, and then that's not happening. That might be that a person is so depressed that they're sleeping all day for most days than not, for weeks at a time. They're not taking care of their basic needs. They're not eating. They're eating too much. And so all of this goes into, hey, what kind of care do they need? If I'm supporting somebody who can't even get out of their bed to come to session with me, and the only thing that I can offer is 1 hour a week, is that going to be enough? And forgive me if I already said this in my lecture for week 1. This is where we have to identify, hey, what does a person need? What kind of structure do they need in order to stabilize and move back to a functional baseline, or move to a functional baseline to improve their functioning? And here's the necessarily level of care. I definitely pulled this from our previous lecture. And so just as a reminder, we have to consider that the severity of the presentation versus the client's readiness or their ability to be exposed to that level of care, that matters. So I could want somebody that's coming in for a substance use disorder issue, somebody saying like, hey, I'm drinking every day. I'm not going to work. I am spending all of my money on alcohol, which you'd be surprised how often that happens. And I'm like, oh my gosh, I can't treat you. I see you once a week for 1 hour, or technically 50 minutes. Like, this is not enough for me to be able to help stabilize you. I would say you need to go into medical detox. The person might be like, hell no, I'm not doing that. I'm not going to the hospital. That's where I would have to read them the riot act and say, hey, if you just stop drinking, all of a sudden you could die. We will talk about that in week 7 with substance use disorders and alcohol withdrawal. But that's where it's less of a choice. But they may be like, okay, fine, I'll go to the hospital. I will get equipped with medication. I will start the process of medical detox on my own, but I am not going to an inpatient treatment facility. I have to really better understand what is it this person is capable of doing, what resources do they have that would allow them to get this necessary level of care. And if they have a lack of insight, or if they are very impaired as far as their decision making, or they have never been into treatment before and think that they are going to a facility with white walls and that they're going to be put in a straitjacket, they are probably going to be a lot less apt to be like, yes, Lindsay, I'll stay in residential treatment for 30 plus days. We talked about how that is not necessarily possible for most people right now. But it might be that they're going to be like, you know what? Maybe I'll try doing IOP. That sounds like the next indicated step. I will do that. And if there are a series of, in this hypothetical situation, if they start in that capacity and it's determined that with their insurance that they'll be able to engage in that type of treatment, and they continued to drink, then most good treatment programs are going to say, hey, buddy, or hey, lady, you've got to come into a high level of care. We can't support you in this level of care. We really need you to be here more. So you're getting more tools, you're getting more support, you're being around a community that has more or less is focusing on the same areas. That's what we would identify as necessary level of care. So when you go through these questions, especially when we do activities in class or if you have assignments to turn in that focus on necessary level of care, this is going to be going back to, hey, what's going on with their level of impairment? And if you think about the options that are available, in combination with what you know about this person, what's your recommended necessary level of care? It does not mean that this person is going to actively go, and that's what you could speak to is like, hey, I know that this person is ambivalent, and so I would recommend that they go to partial hospitalization programming, but knowing that I might be able to really only hypothetically get them to agree to IOP, but you're just going to speak to, hey, what do you see that's problematic? And if they don't get that level of care, how do you see them continuously staying static in their diagnostic symptomatic presentation? Or how do you see this behavior, these symptoms worsening? How do we see them decompensating? And so that's really how we know what the bar is for a necessary level of care. If you have questions on this through the course, let me know. I try to speak to this a lot more now than I have in the past because there's always questions that come up, but I hope that that's helpful. Strengths are such a big factor. They do not do everything. They're not always protective factors as far as keeping a person from suffering, but we want to know what are their external or internal resources, right? How can we tap into motivation? How can we tap into insight, into previous use of coping skills? What has their previous experience at therapy been like? Has it been helpful? Do they have a sense of humor? Are they creative? Have they been adaptive in environments before? Do I say intelligence in here? I do. Intelligence should be a lot higher. Intelligence is always kind of a key indication for a person's adaptability and ability to positively engage in treatment, but sometimes that can cut both ways, where if they're not motivated and they're really smart, they can talk their way out of being in treatment. It just depends. So, what are the resources that we can really use to help deepen their ability to engage in their treatment and to really understand the nature of their problem, and then to be able to utilize the tools that we're trying to give them? Plus, their external resources. What does family support look like? Do they have a lot of friends? Are they in a romantic relationship? Do they have financial resources? Is there a treatment center that's down the street from them? Or is there a treatment center that's an hour away from them? That really makes a big difference. Do they have access to the internet? I know that sounds ridiculous, but that's not always the case. Or do they know how to use the internet? Um, do they have access to their phones? I mean, when we think about the older adult population, these are things that we totally take for granted. And where it's like, well, I'll just I know you're sick this week, but let's just set up a session for a Zoom meeting. They may not know how to do that. And so these are all things that can be hindering or can be tools to be able to help bridge that gap of their positive or disconnected experience in treatment. Do they have accountability through their support system? Have they been engaged in the legal system? Like, what is like keeping them from being able to talk to you about the true nature of their problem if they're so concerned that they're going to get locked up for being honest about it? So how do these resources help or hinder the person in their treatment? So, all these things taken into consideration, we're going to go back to Anika. That's what I'm calling her, Anika. This is how I would start to work through this. Um, I'm going to start with contextual assessment, right? So, this is all of these lines are focusing on her background information, right? How she arrived to um, this place and time where we are treating her and supporting her. So, as I'm highlighting all of this, this is all of the on paper information that helps support our understanding. Oh no. Oh my gosh, I forgot about this. That if I This is like an all or nothing thing. Okay, so it helps us support our understanding of the contextual factors that have made way for what she is presenting as far as what's problematic. Now, this pink is what I'm identifying as possible diagnostic symptoms. So she's uneasy and uncomfortable. She's not happy. She feels lonely and isolated. She could feel happier. Could feel happier means that she knows what it's like to feel happy and she is not feeling that way. Um, Misses her friends and family in India and longs to see them. That could be contextual. That also could be helpful as far as assessment information. She's having a hard time being away from everyone. Oh, that probably might be pink instead. Forgive me. And okay. She hasn't felt motivated to draw or paint since coming to the United States. Again, this is an indication of a move away from baseline. She feels lonely. She misses how she would socialize with friends and family in India. She has difficulty connecting with neighbors. Um, she stays in most days. She doesn't feel like she could talk to anyone who would understand her. She's having trouble sleeping, frequent headaches. She gets worried about things that are happening in her life. She gets very anxious when she thinks about getting a part-time job. She feels sad and worried. So all of this is what we are going to put into the assessment part, not the contextual assessment. This is going to go into the A component of our I Can Start framework. The first A. Then we are looking at her different strengths, right? That we see her role as tending to the home. She cooks and cleans. She provides care to her and oversight to her children. She likes to paint. When she lived in India, she'd make crafts with her neighbors. Now, the green, this is the individual factor for the therapist, right? So this is the counselor in the sense is aware that the communication is difficult and is left with more questions than answers. So this is a counselor like, hey, I really need to figure out how to better understand and support this person as best as possible. So that is how we can start to categorize and again, conceptualize what's happening given a set of information about a person as far as their background and their presenting issues. So now this is where we would engage in treatment components for Anika. What I realized is what I did not do is do differential diagnosis with you in this lecture, but we're going to do it in class. Okay. So this is definitely something that we are going to talk a lot more about in class. But treatment components for Anika would be, I just try to use as many visuals as possible. Our overall treatment objective would be that Anika wants to experience an overall improvement in her adjustment and assimilation in the United States, especially since she's been here for the past 2 years. But currently, she is here because she wants to improve in how she adjusts and connects to her life here. And so the trunk is the treatment approach that we would use. What we've identified is that she has a lot of worry. She has a lot of stress. She feels disconnected. And so we could hypothesize that her thoughts get in the way of her being able to leave her house, of being able to connect with people outside of the home, that she, and there's a lot to be, oh, that's why I didn't do this. There's a lot to be said about what she's struggling with and whether this is clinical as far as warranting a diagnosis or not. That's why I didn't do this. Let me ask you this. Does this seem like something that we have to diagnose? So look at the pink. Look at that in comparison to the orange-ish yellow. Does it make sense why she's struggling the way that she does? Of course it does, right? Like, can you imagine being in another country that does not, we'll just see language aside, that does not emphasize the sense of community the way that the Indian culture does? I happen to have a couple different Indian clients in my private practice right now, which is like totally a fluke. But I've just learned so much about how central Indian culture is and Indian community is. Living in a place where there is a large network of other Indian families, of other Indian people, like that is always the case. It is, no, sorry. I realize that I have an N of 3 right now, but in each of these people's lives that I'm talking about, my client, so central to what they talk about is what's happening within their friends, what's happening within their family, and how the lens of their ethnicity, how the lens of their background makes a difference as far as how they act and engage with others, how they think, they feel, what they do, what decisions that they make. Like it's all conceptualized and it's all contextually valid within the lens of their culture. I know that sounds ridiculous or just obviously redundant, but so for the sake of this, I would not be quick to make a diagnosis because it makes perfect sense that she's been away. And then if we focus on language, like if she's been away from such a strong network of community in her family, like friends and family in India, longs to see them again. She's so far away from home and she cannot speak English fluently. Oh, that'd be so difficult. That'd be so distressing. It's very isolating in itself. And so I would not be quick to diagnose this, but if I had to make a diagnosis, it doesn't quite meet adjustment disorder as far as time because she's been in the United States for 2 years. Adjustment disorder, as we'll talk about in week 10 of the course, is really oriented around a 6-month period of time. We could say that this is something that she meets an unspecified depressive disorder for, or that it's possible that she meets an unspecified anxiety disorder. So we could really do like a baby diagnosis for her just to make sure if she needs to connect or if insurance needs to bill, that we could make sure that she gets the treatment that she requires. So that's why I didn't do a differential diagnosis with this. But I don't want to pathologize this. I want to normalize this, that this is a very normal reaction to anybody that has experienced something like this. And so we don't want to, I'm not saying that making a diagnosis for somebody is pathologizing them, but the context really fulfills our conceptual understanding of why she's suffering and struggling. Regardless, we know that she feels sad, worried, isolated. And so cognitive behavioral therapy is a fine theory to use for this person. What it focuses on are a person's thoughts, how that connects to their feelings and their behaviors. Pardon me if you're like, yes, Lindsay, we already know this. But so this is where we are going to identify what treatment approach, what theory best fits for this person given the context, and what is our overall objective for this person, what are goals that we can create that will help this person achieve that objective in treatment, and what are research-based interventions that will be helpful in serving as a vehicle for each of these SMART goals. So here I have listed, Anika will engage in enjoyable activities outside of her roles in the household 2 times a week. Anika will reduce her anxious thoughts by 50%. Anika will use relaxation techniques to manage worry and stress 1 time a day. Anika will take English classes 2 times a week. And then Anika will increase interactions with others in her community 1 time a week. And that might be a long-term goal. It may not be something that is realistic for us to start off with right away. This is where we go back to what is specific, what's measurable, what is something that is achievable, is this realistic, and then how can this be done in a timely way? And so the way that we formulate our SMART goal statements, these are ideal examples to use. Now, I'm always like on the fence about something that is totally subjective because we don't necessarily know if it's achievable or if like a person can adequately report measurable progress of Anika will reduce her anxious thoughts by 50%. Like what is it? I don't know. To me, that can be too nebulous. In this next slide, what I identify is that she's going to reduce her anxious thoughts by 50% as reported in her thought records. And so that goes back to the the branches: behavioral activation, cognitive rehearsal, core beliefs, identification, identifying automatic negative thoughts, using thought records as a tool to really encapsulate a lot of these different components. And what thought records do is to help track a person's relationship and distress that is experienced by their automatic negative thoughts, by their by their cognitive distortions. And so thought records really help us gauge, hey, how distressing or overwhelming is this thought? What is the subjective unit of distress that we would identify, otherwise known as? And so I hope this makes sense, this visual. But so this is how evidence-based treatment works. It's like, what does this person want? Do we agree with that? Is there a way that we could better, more cohesively outline the treatment objective? What kind of theory are we going to use that really best sets a framework in motion for a person's symptoms and what a person wants? And then what offerings does that theory have that are evidence-based? And what is that going to look like? So not only do we want her to engage in enjoyable activities outside of her roles in her household 2 times a week, or we want her to actually get out of her house more regularly, behavior activation is a way to teach that. Behavioral activation is a way to be able to track that, there's a whole treasure trove of ways to be able to use behavioral activation. But that is definitely just for you all to know, behavioral activation is wonderful for depression. It's wonderful for anxiety. What it says is like, hey, I know that you feel this way. I know you don't want to get out of bed, or I know that you're so overwhelmed that you're not doing anything. But you know what? You're going to put pants on today. Or you know what? You're going to take a walk outside for 30 minutes. And I know you're going to want to do anything but that, but that's actually going to help your mood. If not immediately, sometimes it's not immediately, in the grand scheme of this particular situation, in the grand scheme of this particular episode. And so we are connecting the what with the how. The what is she going to do, and how is she going to do it? How are we going to teach that? So in this slide, in the next slide, you're going to be practicing writing SMART goals in the overall scope of this course. When you write SMART goals, this is what I want them to look like. So Anika will, you know what? We can also say Anika would like to, Anika agrees to, that there are lots of ways to make this client-centered. This is another conversation for another time. But we want this to really be clear. You're going to paint a picture of what is she going to do? How often is this going to happen? You know, when this is like achievable, if you say that she's going to engage in enjoyable activities outside of what she does in her household, like she's going to stay home and watch a TV show, or, well, I don't know, this is what I would do in my time because I never get to watch TV. What are the relaxation techniques that she's going to use to manage and worry her stress one time a day? If she's not doing anything, and she never lets herself do anything enjoyable at home, for us to say the first month of treatment that she's going to engage in it 8 times a day, or that she's going to do this 5 times a week, that may not be achievable at all. So we want to make sure that we are really paring this down to set goals for our clients that not only can they achieve, but that they can feel competent in doing, and that they can get into the groove of what this looks like. And so we don't want to shoot the moon. We want to make sure that this is something that we are aligning with our clients to give them adequate tools for success that are realistic at this point in their lives. One of my supervisors always told me, couch to 5K, but not couch to marathon, right? So like, how are we going to get them off the metaphorical couch and get them to start running and get in the practice of that? But it would never be realistic for us to get somebody off the couch and then running 60 miles a week. I'm a retired runner here speaking, or past runner in a past life speaking. But we would never expect to do that for ourselves or for other people. And that's what I always think about when I write SMART goals for clients or patients. I'm like, could I do this? Like, I've seen different SMART goals where people say they're going to learn 5 different tools in the next month. I could not do that. Like, I could not learn and practice that regularly. 5 is an astronomical amount. So just don't overdo it when you think about this. It doesn't have to be all ones in each metric, but just think realistically. If you can't do it, you all are incredibly functional, high functioning people. If you can't do it, then how is somebody who has been in therapy for their whole lives, they have had some degree of distress and impairment that they've been experiencing for the past 6 months, for instance, how are they going to do it? Right? So this is where we are just very much making sure we are aligning with who the person is, what they're capable of doing, and helping them with that. I realize that I may have repeated this. If I've repeated this from lecture 1, then so be it. It's just reinforcement of this. I can't help but saying it. So anyways, but please do not complete these statements. You do not have to like do a specific thing that is measurable, that speaks to what is achievable, that it aligns with their presenting problem. Don't use the acronym and spell it out this way. Just make sure that all of your SMART goals really follow this particular formula. Okay. Lastly, are there any additional services or referrals that would be indicated to help Anika manage her presenting problems? So would we want to refer her to a psychiatrist for medication management? Given the fact that I'm not quick to diagnosis, that would not necessarily be the first thing that I would prescribe. And that would also be pretty different as far as aligning with cultural beliefs as well. So I would have to ask, like, how do you see this being problematic? Does this seem like something that anything that you could work with another provider on to help with your mood would be helpful for? Would we want to do couples therapy recommendation to help with communication issues? Is the husband thinking that this is problematic? Is he motivated for any sort of treatment? If they need low cost English courses, or like, I mean, I think everybody these days needs low cost something, but do we have any information about easily accessible classes that she could take to help with her English? Are there any local art classes in the community? Are there alternatives to attending Hindi Temple in person? So if she can't attend it in person, are there ways that she can connect virtually? How would we want to use the strengths and the resources that we know have been helpful for in the past, and identify what additional support services could be essential for her to be able to complete these treatment goals and to essentially feel better moving forward. What you need to think about is, how can you manage your competency? What do I mean when I say this? Oh, um, how could you manage your competency challenges in this situation? So what the therapist is saying is like, hey, I really don't know enough about Indian culture. I need to be better prepared. And then it's a question of like, what resources might you need? So how could you better equip yourself to be able to come into the next session feeling more aligned, more informed, being able to really just deepen your understanding, or just even formulate more questions so that you could join and engage with Anika by wanting her to talk more about her cultural experiences of like, hey, this is what I would do if I didn't know. Tell me what it was like. How often would you see friends and family when you were living in India? Oh, I'd see them every day. Well, what did that look like? Well, in the morning, I would do this. In the afternoon, I would do this. On the weekends, I would do this. Like, I would, again, want her to paint a rich portrait for me of like, what did that look like? And so I could better understand how this contrasts. For me to better deepen my conceptualization, or to better inform your experience of feeling lonely and isolated now. So is that it? Oh, okay. I think that is it for this lecture. Yay. If you have any questions, don't hesitate to email me and ask me, but that is the conclusion of our I Can Start model. Like I said, please make sure that you are better preparing yourself for the mental status exam by reading that information. We're going to have opportunities to practice the I Can Start model in class. Thanks, everybody. See you soon. Bye-bye.